Sure. Good morning, good afternoon, and good evening, everyone. Welcome to this town hall. My name is Michael Ligodaro. I am in the Prevention Access Campaign as the Global Director for Advocacy and Policy. I'm joined today by my very good friend and colleagues at GNP Plus, who we are hosting this town hall together, as well as Empath, who are also part of the organizing for this call. And the goal of this call or this webinar was to share and give, background and science, and also method in ways we are preparing to intervene in the monkeypox outbreak. And we have a very, very interesting and fascinating panel. We'll hope to hear from them. And I'm not going to speak too much. I'm just going to go over to them to introduce themselves. The first person we have on today is Anton from WHO. Anton, over to you.
Thanks a lot, Michael, and I will share my slides. So thanks a lot for the invitation. As here you go. I hope you can see them in a proper mode. Right. Can you see them in a presentation mode? Right.
Yes. Yes.
Yeah. So thanks a lot for the invitation. And my name is Anton. I'm working in WHO Geneva and the Global HIV, Hepatitis and STI program, but I will present this very short presentation also on behalf of the emergency program. Sorry, okay, of the emergency program, which actually takes the lead in coordinating the global response to monkeypox outbreak. They have involved the HIV, hepatitis and STI program from the very beginning, especially because the most affected population in these outbreaks are similar to those that we are working usually, and also we have experience with the community engagement and risk communication. So very briefly, the update about the epidemiological situation as of yesterday. You can see this data online, and actually they are updated on a daily basis. So the number of cases as of yesterday were over 53,000 laboratory confirmed cases all over the world, and 18 deaths were reported to WHO. So you can see here also the distribution of the cases by region, and you can also see that the vast majority of cases are in WHO European region and also in WHO region of Americas. So both North and South America actually now have taken over, and they have most cases. So and there are very few cases in countries of Southeast Asia and Western Pacific. We don't know if it's because of the poor testing, or is because simply the outbreak currently is concentrating in the countries of Europe and Northern and Southern America. Also, WHO has, our Director General has declared a monkeypox outbreak a public health emergency of international concern in July, and that means that it requires coordinated response all across the globe by all the stakeholders and member states. So it's the highest level of alert for WHO. So a few words about what we know about this outbreak. So monkeypox is not a new disease or not a new infection, but there are quite specific characteristics in this current outbreak, which started this year. So we started to see cases in countries which were not previously affected since May this year. And in this outbreak, almost all cases, or like the biggest majority of the cases reported have sexual encounters, or the mode of transmission is sexual transmission. And also we see almost exclusively person-to-person transmission. So there is very little role of contaminated surfaces or clothes. There were some rumors or some disinformation. So this is not what we see. So basically, almost all the infections involve close contact with the skin lesions or mucous lesions, and maybe also body fluids. And we also see some specific symptoms, but quite unusual from what we learn from the classical textbook. So they're mostly ulcers, lesions, and sore in the mouth, and also other mucocutaneous lesions such anal, rectal, and also genital lesions. So that's why there is a question where monkeypox is an STI. I think it actually doesn't really matter, because we know that in this outbreak it behaves an STI. So we tend to say it's a sexually transmissible, it's not only sexually transmitted infection, because there are also other ways, but it behaves as a sexually transmissible infection. And common exposure settings. So there were some reports of common exposure settings in parties, bars, and gatherings, and big gatherings. So speaking about HIV and monkeypox, what we know that among all cases reported with known HIV status, 39% are people living with HIV, but we don't have information about all cases. We know that there are similar risk factors and similar risk groups are affected, and there is no evidence that there would be any more severe clinical presentation in people who have well-controlled HIV infection. However, we have seen several cases with the severe presentation with those people living with uncontrolled HIV infection. So either those people were not undiagnosed, or for some other reasons were not on ART. So it's very important. So as long as you are taking ARV, you don't have any elevated risk of a severe or fatal outcome. So what we don't know the relationship between HIV infection and immune response. So we don't know if there will be, if among people who have HIV, if the immunity after, for example, after monkeypox, if it will be as strong as in any other people. And we also don't know all the information about possible interaction between antiretrovirals and monkeypox antiviral therapy. So a few words about available vaccines and therapeutics. So luckily, we already have a vaccine for which should be effective for monkeypox. It was initially developed for smallpox, and some data shows that the smallpox vaccination could be at least 85% effective also in preventing monkeypox. But it's important to know that this is data from studies in animals or from studies in previous outbreaks. We don't really have a real-world evidence in the current outbreak. We assume that this vaccine is largely effective, but to be very honest, we don't have a very solid data, but we are gaining it with every month and every week. Fortunately, supplies are limited, and many countries are facing a shortage and lack of vaccine. And there are two strategies that you can use for vaccination. So one is the primary preventive vaccination, which is recommended for persons at risk of monkeypox exposure, and definitely for people living with HIV, and also for persons from key populations. And the post-exposure vaccination is recommended for close contacts of cases, ideally within 4 days of exposure. There's also treatment available, tecovirimat or TPOXX, which has received some emergency approval in the US and Canada, and also is approved for treatment of monkeypox in Europe. But again, we don't have very solid data on real-world effectiveness of this medicine, and WHO recommends using this medicine in clinical trial or under monitored emergency use protocol. So just finally, the few words about what WHO role in responding to this outbreak. First of all, of course, we provide coordination and liaison with regional offices in member states. We have published a number of technical guidance, including on surveillance, laboratory testing, clinical management, vaccines, advice for travel, and also on risk communication and community engagement. And we also continue monitoring data and providing reports on a regular basis. I can post any of the links to the documents on in the chat for the sake of time. Thank you very much for the attention.
Thank you so much, Anton. Very great information. And please, we're going to have some questions, but I believe folks can add their questions in the chat box. We'll come back to that after the presentations. I'm going to go over to Hank Tomlinson, who is the Deputy Operations Officer for U.S. Government Global Monkeypox Response Team. Hank, over to you. And
hey, thanks. Can you all hear me okay? Great. It's not a great idea to move into a new office and have to set up all the audio-visual equipment yourself the morning of a webinar. But nevertheless, it's a pleasure to be here. And I want to thank the organizers for convening today's session and also thank the other panelists for their contribution. So my name's Hank Tomlinson. I am the Deputy Operations Official for the U.S. government's global monkeypox virus response team. Outside of this, my typical job is as the director of CDC's Division of Global HIV and Global Tuberculosis. And so it's good to be with so many of you whom I know and see so many familiar names in the chat. The first thing that I'd like to do is kind of tell you about the US government's global monkeypox virus response team, which is a couple of weeks old at this point, but reflects a coordination and communication effort across the whole of the US government, its departments and agencies, many of whom have been contributing to global monkeypox virus response in this outbreak since it was first observed, but also for decades. In countries that have previously reported monkeypox virus transmission. And so we are a collection of departments and agencies throughout the US government. Some of the groups contributing are familiar names that you all engage all the time, but there are also groups in the US government contributing who make contributions sort of internal related to policy, administration, and management. Jeremy Konondyke from USAID, who has spent the last year and a half as the executive director at USAID for their COVID-19 response, is the senior operating official. I'm the deputy operating official, and we are supported by a secretariat and have work in a variety of different lines of effort. And so our goals are to support USG activities to help end current outbreaks in global settings, avert wider risks, and to prevent future epidemics. And so we want to address transmission, morbidity, mortality in a number of settings now. That is through engagement, through partnerships, through the provision of technical expertise and commodities, as well as diplomatic and other kinds of engagement. The kinds of things that we're working on are data reporting and planning, strategic communications, diplomatic engagement and country coordination, using the US government's reach into more than 100 countries, outreach, education, risk communications and prevention, testing, surveillance and response, and then medical countermeasures, reducing morbidity and mortality, and preventing zoonotic spillover and zoonotic spillback. And so we've worked, and I think I'll talk about 4 primary contributions in global monkeypox virus response. The first is before this outbreak, and then the others build on those historical efforts. And so departments and agencies in the United States government have worked in countries where monkeypox virus has been historically reported, so before this global outbreak, including Nigeria, the Democratic Republic of Congo, Cameroon, the Republic of Congo, Sierra Leone. We've also worked closely and provided support to the World Health Organization and others to develop training materials and to do work in country. That work in these places and more broadly has supported efforts to improve diagnostics, to improve surveillance of monkeypox virus, ecological investigations, training field epidemiologists, training clinicians and training laboratorians, and monitoring high-risk animal-human interfaces to make sure that we have an idea about zoonotic issues. And so I think that that work has lasted for a couple of decades. It continues now. And in the context of a coordinated response, we're trying to determine what we can do in an accelerated manner in countries that have historically reported monkeypox virus transmission. And so in addition to those efforts and building on them, I'd say that there are real attempts to build on our current U.S. government global health contributions and the President's Emergency Plan for AIDS Relief, or PEPFAR, COVID-19 seen over the last couple of years, global health security, malaria control, and global tuberculosis, and a variety of other issues. We spend, and you might hear more about this from Maureen in a little bit, more than $1 billion a year on health system strengthening and public health function improvement through PEPFAR alone. That supports tremendous capacity development and ongoing active support for laboratory, for clinical work, for diagnostics, et cetera. Those can all be applied in this setting in places where those contributions have been made recently and historically. In those global efforts across the domains that I mentioned, there's deep community engagement, including expansive work with gay, bisexual, and other men who have sex with men. There's also support for clinicians, which is a necessary sort of activity for developing a high index of suspicion and being able to quickly identify new cases in this outbreak. The third thing, and so the first was our historical work. The second is building on existing U.S. government investments in global health. The third thing I would say that we're working on is trying to control monkeypox at home. So the U.S. has reported more cases, almost 20,000 as of last Friday, than any other country in the world. And we know that an outbreak anywhere can be an outbreak everywhere. And so we are trying to share information widely. Monkeypox can be transmitted in any group. So it's been reported in men and women in pediatric cases, but we know that gay, bisexual, and other men who have sex with men are experiencing a disproportionate burden in this monkeypox outbreak. And so we want to make sure that our efforts equitably address the needs identified in the United States, and that will help health security in other settings. So sharing information widely, ensuring members of communities most infected are at the center, caring to not stigmatize or use stigmatizing language, and finally, administering vaccine, therapeutic, and other medical countermeasures. As of last Wednesday, when CDC updated its website, 30 jurisdictions had reported their vaccine administration and had reported administering more than 350,000 doses. And while there is a limited global supply of vaccine, and we've seen a sort of plateau or a decline in a number of countries based on non-pharmaceutical interventions, that's an important part of our strategy at home. Noting that greatest number of cases reported here, if it's contained here, it can also provide significant contribution in a global context. And then finally, I'd say engaging with multilateral institutions, global health leaders, other countries, and their national public health institutes. So technical exchange is incredibly important here. Just over 1% of monkeypox virus reported cases, so that's laboratory confirmed reported cases. And we know that lab diagnostics and reporting isn't ideal in a number of settings, but just over 1% have been reported in what the World Bank would call low income or lower middle income countries. So that means that just under 99% of cases have been reported by high income and upper middle income countries. And so technical exchange with those partner governments, their national public health institutes, and other geopolitical bodies is really important. That helps ascertain sort of data, global trends, need for medical countermeasures, and non-pharmaceutical interventions. And it helps us explore the opportunities for partnership and global intervention. And so I've run over time, but there's more to say, and I look forward to the question and answer period. Thanks.
Thanks so much, Hank. I believe folks could not have questions, so I'm going to come back to you in a minute. But I'm going to move to our colleague from UNAIDS, Eamon Murphy. Murphy is the Deputy Executive Director for Programs at UNAIDS. Murphy?
Thanks very much, Michael and colleagues. Let me join others in thanking Prevention Access Campaign, GMP+, Y+, Impact for this timely town hall meeting. It's really important that we look at the lessons of other responses to pandemics, epidemics in other settings, as we just heard from Hank, some of the experiences. 40 years of responding to the HIV epidemic. Many of the partners on this call and others have generated significant experience and lessons learned for all of us. And this accumulated knowledge can and needs to be applied to the response to monkeypox. Some call it an outbreak, but we're seeing it spread quite widely. So we have to be prepared, as Hank was just saying. An outbreak in one place can be an outbreak anywhere and in different parts of the community. We have learned from HIV, and again, recently we saw the same mistakes and the same bad pathways, if you like, in COVID-19, that restrictive and stigmatizing measures lead to significant human rights abuses and with disproportionate effects on already vulnerable communities. They often undermine the responses, the epidemic responses, sending people with symptoms underground and failing to address the underlying barriers that people face in attempting to protect their own health and the health of others in their community. And we are again seeing stigma and discrimination rising with monkeypox. I was on a call last week with Dr. Tedros from WHO, and we are hearing so much from colleagues in Latin America about rising stigma and discrimination and even institutionalized stigma and discrimination being played out in the responses. Given we all know that communities of gay, bisexual men and other men who have sex with men, including those living with HIV, are disproportionately affected at this time, responses need to be mindful of this intersectional stigmatization and discrimination, both on sexual orientation and HIV status. And we've seen that play out in the media and other ways. In countries where these communities are already criminalized, there's even, of course, a greater expected risk for stigma and discrimination. We also need to collectively work harder to ensure that people living with HIV are on treatment. As we just heard from Anton's, that untreated HIV infection appears to be a risk factor for severe monkeypox disease. Now, there are people who are not on treatment, some who don't know their status, but there are plenty of examples where we need to collectively mobilize and encourage people to access treatment. WHO is leading the response collectively, but we all have a role to play. We're working closely with WHO. And as we're hearing today, all different parts of the community response, institutions, governments, we need to involve the science community, the medical community, governments, communities, and other partners equally. Given the varied impact of monkeypox across countries and regions, as Anton was showing, where it's shifting and the higher burden, the approaches and solutions will be tailored and different in these contexts, but must be developed in partnership with local communities from the outset. We can't repeat the same mistakes of the past. So we need to mobilize the investment and leadership to make sure that the response does not reinforce inequalities. Countries need to show the solidarity and together with manufacturers, suppliers, work on solutions to these issues of the insufficient supplies of vaccines and other treatments, the tests as well. This must also include people in the endemic countries in West and Central Africa who have been left behind with this for some time. I can't emphasize enough that the response to monkeypox needs to be centered on community engagement and leadership. Time and time again, we have seen this as the backbone of successful responses to HIV and other outbreaks, COVID-19 in many places as well. And any response will only be effective if the affected communities are meaningfully involved in the development, implementation, and monitoring. And if the community members in countries have not yet been brought to the table as part of the response, this should be a first priority. This inclusion is all the diversity of the communities are affected. Young people, migrants, sex workers, people living with HIV, people of color from queer communities need to be fully engaged in the outbreak response. Community-led responses to the outbreak, including prevention and awareness raising campaigns, also need to be fully funded and supported. I was shocked to hear last week data not being openly shared with community organizations involved in the response in some countries. We know better. We have learnt so much from this, and we need to hear from organizations that are finding it difficult to get the information. Now, our country offices, along with WHO, stand ready to support this response. And we've got some great examples of where we've all collectively come together. We know that in the face of any epidemic or outbreak, the most vulnerable communities will be the ones that suffer the most. So social protection measures are needed. People who need to isolate for long periods of time need to be supported. We saw that in COVID, where people had to make some very difficult life choices. And so if we want to help contain monkeypox, we need to be supporting the community members in all areas, including social protection. So finally, we need to be clear that this will not be the last outbreak or epidemic that the world will face. And Hank was just talking to some of this. Governments need to build adaptable systems capable of addressing the multidimensional aspects of pandemic prevention and preparedness. We need comprehensive and integrated health services harnessed through universal health coverage to ensure equitable and affordable access to health for all. Our offices are working closely with all partners. PEPFAR's mentioned here, the community, Global Fund, a whole range of others in working on this issue. We can't see these outbreaks or pandemics like HIV in isolation, and we need to be working and learning from the successes and the failures of them to build those resilient systems for future outbreaks. Let me close, given the time, it's be interesting to hear from the panel and the discussion. I'd like to acknowledge that all community-led organizations and the networks led by gay, bisexual, and men who have sex with men, I'd really like to appreciate their leadership in responding to this outbreak. We've seen some of the best examples where they've been at the forefront of the response. We in UNAIDS are a firm believer in the centrality of this community leadership to raise awareness of monkeypox, as it has with HIV, to help community members protect themselves and their loved ones, and to fight against stigma and discrimination, a free and equitable response. So with UNAIDS, we stand with you and look forward to supporting you. Appreciate having sessions like these globally, regionally, and at country level to share the information. Knowledge is the power to help people understand how to prevent monkeypox and to respond to it. Thanks very much. Back to you, Michael.
Thank you so much, Eman. And this is very, very important. And again, we have a couple of questions, so keep them coming. We're going to try to get to them during the Q&A segment. So I'm going to then move over to our panel conversation. And again, this is a very interesting time to be talking about this. I think before I just move on, giving again to Hank and Anton, given that, in the last couple of weeks or two, we've seen drastic reduction in cases of monkeypox. Like, is that going to affect the response moving forward? And what is your recommendations to that, just before we go to the panel? I think that's so critical because people are asking, now that we know that the cases are dropping, are we going to change the way we're responding to it? Is this still like needed? Like, how do we sort of answer those questions?
Anton, do you want to go first?
Yeah, maybe I'll go first. So if I understood correctly, the question is that we are seeing a drop in number of cases in monkeypox, yes. And I think it's not actually, if you look globally and also you look in all the countries, that may be the case in some countries in Europe and in Germany, in Portugal, and a few other countries, but it definitely doesn't look that's the case in countries in South America, for example, in Peru or in Colombia or in a few other countries. So we don't know, and the situation can change in any moment. We know that also the virus can change, or it can enter another population. And now currently there is a conference happening in Zimbabwe, and I think there was a presentation of a series of cases which were documented in heterosexual transmission in related couples, and that this is also worrying, and also we know that the same was with HIV. The epidemic is different in different countries because of different vulnerabilities. So I think we shouldn't relax, and we need to closely monitor and continue building the response. I think that's in short. I know I cannot.
Yeah, thanks. So Michael, thanks for the question. Anton's, I'm in agreement. So I think that, Michael, the answer is it's too early to know. We have seen in some European countries that there has been a decline. Well, in some, a slower rate of growth, in some, a plateau, and in some, a slight decline. That mirrors what's been seen in a number of very large North American cities who were sort of hit quickly with sort of rapid growth early on. But in the Central and South American countries, we are seeing not that pattern. And so epidemiologically, we're in different places depending on geography, and it's too early to say. So we will continue to follow epidemiologic trends and use that information to calibrate the response. But I think that it's also really important that we as a community of actors and a community of affected people understand that when something is controlled at home, or we might feel reduced risk for acquisition, that doesn't mean that it goes away in global settings. And monkeypox has been historically observed in a number of countries in West and South Central Africa. We also don't want monkeypox to become something that is commonly observed in the places that the 100+ countries that are currently experiencing outbreaks. And so we've got a job to do to keep driving cases down. And we want to make sure that monkeypox doesn't become commonly observed or endemic in either new populations of people, animals, or in new geographies. And so I think we want to keep pushing in that direction. I think that global attention, the sort of possible provision of resources from different contributors in different settings, those, I think, have the potential to be responsive to the dynamics and the trends that you observed. And so we're aware of it, but I'm trying to, I think, push forward.
Thank you. Thank you so much. Super great. So given that, I'm going to hand over to our next panelist, just a couple of questions, but also I'll ask them to introduce themselves. Mark Thompson and Jay and Larkin and Emily and Maureen, sorry. Who's going to go first? Mark?
Hi, good afternoon. Thanks, Michael. I'm Mark Thompson. I'm the director of the Love Tank based in London. We're a community interest company that works around health inequalities in marginalised communities. And we've been doing quite a bit of work here in the UK around monkeypox.
Thank you. Jay?
Sure. Good morning, good afternoon, everyone. My name is Jay Gilliam. I'm the Senior LGBTQI+ Coordinator at the U.S. Agency for International Development, which is the U.S. government's lead foreign assistance agency.
Thank you. Maureen?
Hi, good morning. I'm Maureen Barty. I'm the Senior Advisor for Health Systems and Health Security at the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR. It's great to be with you.
Thank you. And Larkin?
Hi, everyone. I'm Larkin Callahan. I'm the head of global advocacy and community engagement across the virology portfolio at Gilead Sciences. Thank you so much for including us in this panel.
Great. So I'm just go over to you, Mark. Given your engagement and involvement in sort of getting the vaccine and access to vaccine for specifically people of color in the UK and London specifically for monkeypox, what has been your experience so far? And can you share more about your experience, but also issues around stigma for community of color, and especially given that there's been some, lack of access to vaccines for gay men of color, Black gay men specifically. Can you speak more about that?
Yeah, sure. Thank you, Michael. It's a really good question. So many of your colleagues on the call would have seen that when monkeypox first hit, we had quite a strong response in the UK with setting up vaccine sites in lots of spaces, usually within clinical settings or hospitals. We called them supervax events, and they were really successful in the early part of the summer. And they were a great way of getting gay, bi, and other men who have sex with men out and engaged in vaccine. And what was really encouraging was men were telling each other, were using social media, and were really engaging and acting for their best interest and for that of the community. But what we observe at the Love Tank, because we are quite firmly based in our communities, that when we were observing those queues, and we were also getting anecdotal reports, that when we looked at those queues, they were overwhelmingly made up of cisgendered white men. They were overwhelmingly men from urban settings. A lot of the supervax events happened in central London. And if you know central London, I mean, that's where the hub of all activity is. And they were usually happening at the weekends. And for some of the men from Black, Asian, and other minority communities, racially minoritized communities, and for men also whose first language wasn't English or were migrants, they reported a number of issues to us. Well, firstly, the ability to get to a supervax event at a weekend, if you live at home, if you're a student, if you're economically deprived, even if you're working at the weekend, how can I get there? There was also the issue that people were seeing these posted all over social media. So if I'm a young queer man of color who's not out to my family, am I taking a risk by being there. Finally, we were also getting anecdotal reports from people who were identifying as trans men or non-binary were being triaged out of those settings as well. So they had real concerns about pitching up for a vaccination and being told you don't fit the criteria. So we decided to act very quickly, and we worked with a local NHS trust, National Health Service Trust here in London, to organise 2 what we called under the radar pop-up events, which we tagged onto existing community events that we were participating in. And I'll just tell you very quickly, because of time, about both of them. The first one was an event that we had organised for men of South Asian origin, which was meant to be a focus group, a brunch, and we tacked on the availability of 40 vaccines at that event in the afternoon. We didn't advertise it in advance. We set up, we only told the men when they arrived the vaccine was available that day. All of the men took it up. Now, the reason we didn't promote it more widely is because we knew that we would be flooded with men who weren't from that community. So we're very clear about that. The second event, one of the biggest festivals we have in the UK, is UK Black Pride, attracts between 15 and 20,000 people here, held at a weekend in August. We spoke with the organisers there and we said, look, we can get a bus in the venue which will be staffed by clinical staff, by a pharmacist, by vaccines, by doctors, and we will provide vaccine to men there. And we were able to vaccinate 260 men between midday and about 3:30 on that day. The response was overwhelming. Now, the other thing I just want to bring to colleagues' attention was not only were men coming along getting the vaccine, there were a number of men that had come there to the event who were either not British born or were very, very young and were not plugged into any sexual health service at all, or didn't understand how sexual health services worked. So we were missing men who were not getting gonorrhea tests, chlamydia tests, or HIV tests. There was one case where a man wasn't getting HIV treatment because of his migration status. And just by coming and getting a vaccine, he now understands that he can get his treatment for HIV for free. So I think it's really important to kind of, the headlines to pull out from that was a highly targeted vaccination events, which are time limited in scope and duration, which are specifically for groups of men, work really, really well. The second thing is we then capture men who are falling between the cracks of general health and other services. So those are the wins for us on those. And we hope that with more vaccine becoming available, that we will be commissioned to deliver more under the radar events at specific places where men from those communities go to. So I'll leave it there and I'll pick up on other questions on stigma, etc. later. Thank you, Mike.
Thank you so much, Mark. Again, just given what Mark just described and also what Murphy and Enk and Anton spoke about earlier on, I think it's really important that we learn from HIV, but I don't think we have done that. In terms of how we responded to monkeypox, I think we are using the same playbook and sort of going to the same people and the same leaders to sort of look for the same structure they've used historically to respond to monkeypox. And they were having the same issues around access, around stigma, around racism in the response. So Jay, I'm going to go to you. Given your own leadership and role at US government response and to monkeypox, and also knowing that, you know, your own personal experience as well, how is US government, USAID and LGBT team trying to advise or provide recommendations to US government on how they respond to monkeypox, and given the historical background about stigma and racism and LGBT sort of discrimination, what is USAID doing to make sure the response is different from the usual?
Sure, yeah. First of all, just thank you for the event organizers for letting me join the panel of experts and leading scientists for this really important conversation on outbreak. You know, as many folks have already mentioned, infectious diseases like monkeypox really know no borders, right? And so we must have a coordinated response among international and local partners, each bringing together all of our comparative advantages to this outbreak. And as you have already heard from Hank Tomlinson, ending the monkeypox outbreak is really critical for the US government. You know, at USAID, you know, we are coordinating with our departments and agencies in the US government, like the National Security Council, like the Centers for Disease Control and the State Department, to really ensure that there is a whole of government response to the outbreak, and making sure that we're achieving our shared objectives and really key results. I think USAID brings a lot of significant experience and investments in working with national health systems and civil society organizations in our partner countries to really help them be better prepared to prevent, detect, and respond to infectious disease outbreaks like this. And we already have been providing international support to the monkeypox, where it's been endemic in a number of countries that Hank mentioned earlier. And I think these investments are really making an important foundation for our USAID partner countries around the world to be able to respond to this outbreak. Currently USAID is providing $15 million of funding to respond to the global monkeypox outbreak. And that is really prioritizing assistance for the response in low income and lower middle income countries. And this type of support is really depending on the needs and the priorities of our partner countries, but that assistance can include laboratory and testing support and surveillance in terms of infection prevention and control, personal protective equipment and technical assistance for the development of preparedness and response plans, and around community engagement and communications efforts there. And, as USAID's senior LGBTQI+ coordinator, an area of great concern for me has been how to best support our partner countries in combating the stigma around monkeypox, given that this disease, as we all know, is disproportionately impacting members of our LGBTQI+ community, particularly gay and bisexual men, men who have sex with men, and trans women. So, immediately following the initial outbreak in June, we saw a number of governments and media outlets around the world just really seize the opportunity to amplify populist homophobic rhetoric and to label monkeypox as a gay disease. And so, in response and in parallel with our ongoing support to the monkeypox response globally, USAID has been conducting extensive outreach to key stakeholders group, including the LGBTQI+ community, to really raise awareness about the outbreak and to share updates on vaccines and testing, and to hear directly from the community and to combat stigma. And I think we've heard from a number of speakers already that going to the community is really important, that we are hearing from them that part of the response that we are doing is coming from the community, because they know best what their needs are and how to reach people, like Mark said, in terms of getting to folks that might not be the normal go-to folks that we are working with. And then we're also just reminding our staff, especially through our global network of our mission-based LGBTQI+ points of contacts and implementing partners, that the LGBTQI+ community should not be further stigmatized through monkeypox. And that is really important to make sure that they recognize that stigma can be happening, and that they have the resources, the right language to be able to combat them with either host government partners or other partners that might be stigmatizing the LGBTQI+ community. And so, with every new global crisis, we continue to learn and just adapt our responses in this ever-changing environment that we're in. And at USA, we remain committed to working with partner governments, with public health experts, with local stakeholders, and bringing in new folks into that to help make sure that we are really learning from previous responses, from previous outbreaks, and really strengthening the global health systems that we've been able to help produce by bringing in more folks that are being stigmatized, and to be able to really just combat that. Over.
Thank you so much, Jay. Maureen, I'm going to go over to you. Given PEPFAR role and how PEPFAR sort of responded to previous pandemic, especially COVID and obviously HIV as well. So what is PEPFAR thinking of doing differently in terms of this response, given what Jay and Mark just spoke about, and also given that most of your sort of partners are not necessarily community-led, I should say. What are you doing differently to make sure the response is really community-led and community and focused in terms of monkeypox?
Thanks, Michael, for the question, and thanks to all of the organizers for inviting us to participate in this panel. It's a really important and timely discussion, so thank you. I think, as Hank mentioned, and Jay as well, PEPFAR is working as part of a broader coordinated U.S. government global monkeypox response. And I think that's an important distinction. the US government is really pulling together to ensure that we're learning lessons from our previous work in HIV and also from our response to COVID-19, and trying to apply the lessons and what went well and what didn't go well to our responses, our long-term response to HIV, as well as our less time responding to COVID-19, and applying that as we're responding to the monkeypox virus. PEPFAR specifically has remained committed to continuing essential HIV prevention and treatment services while maintaining a safe healthcare environment for clients and staff. And in order to meet our commitment to uninterrupted care and treatment for people living with HIV and the prevention of deaths among people living with HIV due to HIV-associated comorbidities, PEPFAR is committed to adapting the HIV services so people living with HIV have the best possible outcomes within the context of stretched healthcare systems. And these principles apply to both current and future pandemics. And it's hoped that the investments that are made in health system strengthening will foster resiliency in the current context. And as many of you know, Ambassador John Nkengasong recently released his strategic direction for the future of PEPFAR. And one of the 5 pillars of this direction is health systems and health security. So leveraging our PEPFAR platform to protect HIV gains and strengthen health systems so partner countries can rapidly respond to future outbreaks and improve broader health service delivery. And we've been reminded by the COVID pandemic and the monkeypox outbreak of the importance of this pillar, that we need to ensure the systems that we've built and continue to build to end AIDS by 2030 must be resilient to new and re-emerging threats. So as with our response to COVID-19, PEPFAR is applying similar program guidance to the monkeypox response in the context of seeking to achieve the best possible outcomes for people living with HIV, their families, and communities. And we're engaging our human resources, surveillance, and diagnostic platforms, sample transportation, data systems, and waste management biosafety that support diagnostics. We're also utilizing existing community and public health networks for risk communication and prevention messaging to the populations most at risk for monkeypox, including people living with HIV who may be immunocompromised. And I think one thing that we're realizing is that some of the adaptations that were made for COVID are proving to be very helpful. And we're thinking, how can we extend those adaptations for the response to monkeypox? And one example in particular, data shared at the International AIDS Society conference suggested that expanding multi-month dispensing of ARVs was associated with improved viral load suppression. And if you look at expanding that beyond the countries that are doing it right now and the locations that are doing it, that can keep people virally suppressed, which also, as we heard earlier from Anton's, potentially then more protected from monkeypox. So I'll leave it there and hand it back to you, Michael. Thank you.
Thank you so much, Maureen. Before I go to you, Larkin, just to go back briefly to Mark. Mark, you had a point about health inequalities and PLHIV.
I did, yes. Thank you, Mike, for coming back. It was just to pick up on a point because Hank and Eamon and Anton have all kind of mentioned this. And what concerns me is we saw through COVID and we've seen through HIV is that there are severe health inequities. And we can talk about people with HIV taking their treatment or getting the message in and these sorts of things. But we also know that those people with HIV very often are at the bottom of the barrel, have the poorest outcomes. If we just look at the United States and Mississippi with some of the highest prevalence and some of the lowest health outcomes and the highest rates of poverty, that these are the communities that are least likely to engage with our messaging around monkeypox, least likely to have access to treatment, and therefore least likely to have social, economic, and psychosocial issues to manage good adherence and therefore viral suppression. So all of these factors make them incredibly vulnerable to monkeypox if they were to get it, etc. So I just think for all colleagues that when we talk about people with HIV, when we talk about this issue, we cannot do it unless we're coming from a standpoint of understanding those severe inequities which already exist and will only be exacerbated by the current situation. So it's just to call out to constantly remind ourselves that we're not all on a level playing field.
Absolutely, I couldn't agree more. And again, I think, both from UNAIDS and from WHO and from PEPFAR, I think there's been a sort of a usual call for sort of intervention and sort of focus and funding for structural interventions. And I think these structural interventions are key in terms of preventing new HIV infection, in terms of keeping people on treatment, but also responding to inequalities like this. But I think in the last couple of years, there hasn't been a lot of attention paid to that. I think we have to, in order for us to respond to issues like this, monkeypox is not going to be the last virus that comes along. We're going to be several others, and we know communities are going to be in the forefront of it. Until we sort of provide significant funding and respond to those issues, we are not going to get anywhere. So with that being said, I'm going to go to Larkin and given the time frame that we have. Larkin, Gilead recently announced a new funding opportunities for community-led organizations and current grantees. Can you speak more about how Gilead came to that point of view, but also like in the last couple of years, what you've done working communities beyond the work they currently do?
Sure. Thanks, Michael. And thanks to the organizers again, reiterate how grateful I am to participate on this panel and share some of the work that Gilead has done. So throughout our history, most folks know Gilead's worked with community organizations to address some of the more critical public health challenges and disparities, particularly those faced by the LGBTQIA community and among those impacted by HIV, given our virologic focus. And while we are a biotech research company, we know that science alone is not going to end a crisis like monkeypox, just like science alone is not going to end HIV. Folks have reiterated here. We also need to urgently address not just the root causes that drive it, like lack of equitable access to healthcare and trusted information, but also we're in a position to address the profound direct and indirect consequences that it unleashes, like service interruptions at community organizations and fairly significant financial burdens for those who are affected by or fighting the disease. So this kind of approach requires a collaboration not only with larger advocacy organizations, but also with the more locally driven community organizations, as all the other speakers have reiterated here, working closely with those most impacted. And Mark gave a great example of that. So we announced just a couple of weeks after the WHO declared it a global health emergency that we're providing a $5 million grant funding collaborative for immediate action with some of the leading LGBTQI advocacy organizations, as well as those working more closely with communities on the ground. So in needing this forceful and rapid response, we selected a few key areas of focus and the partners best positioned to address them. So education, vaccine hesitancy, and a global outbreak emergency response fund. So deploying the public education and vaccine hesitancy communication campaigns, obviously important so that the affected communities can receive timely, accurate, trusted information, and that folks are able to make the most informed decisions about how to prevent and treat monkeypox. As everyone has reiterated, this outbreak has been accompanied by confusion and stigma. We know that prevents individuals from seeking or receiving appropriate care, which obviously thwarts our efforts to stop the spread of this virus. Vaccines and treatments are not sufficient if affected communities don't know about them. And Gilead, has been schooled in that in the past around HIV. If people aren't sure how to get them, lack the confidence that they're safe and effective, if they're uncomfortable initiating a conversation with an HCP because of historical stigma, it doesn't do much good. So we partnered with GLAAD, the Human Rights Campaign, National Black Justice Coalition, and National Center for Lesbian Rights, and NMAC. They were given larger grants to sort of tackle the education and outreach component of this. Establishing a global outbreak emergency fund was also key. So we are providing grants of up to $50,000 to some of our existing global Gilead grantee organizations that are working in regions around the world that have active outbreaks. Disruptions, again, like this outbreak, have the consequences of for community organizations like unexpected overhead costs, developing educational materials, service interruptions, PPE for healthcare providers. We want to make sure that we're supporting our grantees who are doing that essential work on the ground as they seek to provide the continuity of those services during this time. We know that many of them are diverting funds from HIV. We heard from our grantees immediately that they were diverting funds to address monkeypox. And so we wanted to get on the ground as soon as we could. We've also always understood that community-based organizations, again, as Mark reiterated, tend to possess the local knowledge, the relationships, the credibility that are really essential to fighting these outbreaks, particularly when there is such strong stigma around those communities. The fund is open through the end of September. We will extend the date if we have remaining funds. And while it addresses the immediate needs of the impacted communities, it provides the essential sort of security to these organizations that allow them to brainstorm longer term solutions to this emerging crisis and plan for future crises. As we said, this is not going to be the last outbreak. While we are a pharmaceutical biotech company, given that we don't manufacture monkeypox vaccines or treatments, we want to make sure we're leveraging the resources we do have and the partnerships we have for these key, non-pharmaceutical interventions. So I'll leave it there and happy to answer any further questions.
Thank you so much again, everyone. We're going to go a little bit back to the Q&A to see if we have any questions from the group. I know some of you will have to drop off, but Jacqueline, you want to take over this segment?
Yeah, thank you very much, Michael and everyone. There have been quite a number of questions that have been asked, and I also thank Antons, who has answered some of them, actually answered almost all of them.
Yeah.
Yeah, so I'm sure members have access to the Q&A box. If not, please let us know so that we can answer them. Also, you can raise your hand if you have any question, and I think we can give you access to speak if I'm not mistaken. Lesego, is that right? All right, Anton. Yeah, Anton wants to respond. Yeah, go ahead.
Yeah, maybe just to know that I tried to respond the question in case there will be no time, but if any of the panelists has anything to add, or because I mean there could be more to those questions. For example, the question about the vaccines. I mean, I wrote that there are currently 3 vaccines are available in globally, and 2 of them are replicating vaccines, so they're similar. So I think they're 2nd generation vaccines, and they are similar to old type smallpox vaccine, which actually are replicating, and they're creating this scar. If you may remember, 40 years ago there was smallpox vaccination, and they're not recommended, or they're not totally safe for people who can have immune deficiencies. But the one which is most widely used, the so-called Imvamune or Jynneos, or it's known by other names in different countries, it's not a replicating vaccine, so it's recommended also for people living with HIV, and actually people living with HIV should be also prioritized, and it must be safe. And also we hope, and most likely it is effective, because it has shown in previous studies and also in animal studies with animal, that is effective against not only smallpox but also monkeypox. But we still have to generate solid evidence that is also effective in real life and in different populations, also among people living with HIV, because there could be a different level of immunity. We don't know yet, but I mean, but there is a it must be safe, and there is already this emergency approval for those vaccines. Yeah, over.
Yeah, thank you very much. There is a question to Lakin. Gilead announced recently that they are also accelerating and expanding their early stage antiviral drug screening program to identify new molecules for potential future treatment of monkeypox vaccine infection. Any updates?
No updates on that right now. That research is still underway for both therapeutics and vaccines.
Okay, thank you very much for that. I think there is one question that I'm sure any of the panelists can respond to. They also wanted to know if the vaccines for monkeypox, are they safe for pregnant and breastfeeding mothers living with HIV? Anyone who can respond to that? It wasn't particular to anyone. Please go ahead.
I'm going to say, Anton, you want to try?
Yeah.
I think, yeah, with those vaccines, actually, I mean, since we don't have very solid evidence for most of those questions for those vaccines, so I think as a precaution, I think there is a recommendation against vaccinating children, or not against. It's not recommended for children because there is not enough evidence. And as I know, there is also not specific. There are no specific recommendation for vaccinating pregnant women, because also there is not enough evidence. But there's also a question whether there is indication for pregnant, because currently vaccination is recommended for people who are on ongoing risk of monkeypox transmission. So it's not recommended to everyone. So even for gay men, for example, or men who have sex with men, speaking more widely, it's not recommending for every man who have sex with men. Right? It's for those who have multiple sexual partners, those who are on PrEP and so on. So yeah, it's not an easy question to answer, but yeah, we are generating the evidence on safety and on effectiveness of those vaccines.
Thank you so much again. Thank you. Sorry, Jack. Go ahead.
No, Michael, go ahead. Please go ahead.
Okay.
Yeah.
Thank you so much again. I know that we are top of the hour, so I know folks want to drop off, but I just wanted to say thank you to everyone who joined, and the panelists, and I'm going to over to Wim to wrap us up.
Yes, thank you, Michael. So yeah, on behalf of the organizers, I'd like to thank all the panelists and all the participants. This was a webinar which specifically focused on people living with HIV. So the global network of people living with HIV, GNP Plus, is very happy to be involved and to work on protecting our community as best as possible. It also mentioned key populations in the title. So I would just like to perhaps draw the attention that there are some key populations that may not be thought of immediately, like prisoners and other incarcerated people. So we should not leave these people behind either. Well, Anton and Mark, they have mentioned that about 40% of the cases currently are in people living with HIV. So GNP Plus and the local PHIV networks, we are very, very much ready to step up the actions that are needed to protect our communities and to make sure that there's access to both treatment and prevention. And also perhaps, again, to make sure that people living with HIV are prioritized for vaccines. But one of the fears we may have is that once that the current outbreak in the global north is contained, that the endemic countries will be forgotten again. And so we should not continue this vaccine inequity and treatment inequity. I understand there's in Ghana, which was not an epidemic presence prior to June, there were about 200 cases already, and with one death. So, and of course, no treatment or vaccines available there. I think I'll leave it there, and this is hopefully just the beginning of more conversations about this, and you can count on GNP Plus for that. Thank you.
Thank you so much. Again, this is a series of webinars. We're going to be having several others moving forward on this topic. So thank you for joining and have a great day.